CST, that is cavernous sinus thrombosis. Cavernous sinus thrombosis is a devastating condition, with mortality rates of up to 30% even with treatment. Of survivors, the majority will have permanent sequelae. In the pre-antibiotic era, mortality was virtually 100%. When it occurs, it is most commonly the result of infection of the central third of the face, the paranasal sinuses. Rarely, cavernous sinus thrombosis may result from non-infective causes. The best imaging modality is MRI. If MRI is unavailable in an urgent timeframe, CT venography may be used. Let's look at the etiology. Most cases of cavernous sinus thrombosis are septic in origin and arise from acute infections in otherwise healthy individuals. Cavernous sinus thrombosis, often secondary to infection from orbital cellulitis, a cutaneous source on the face, or sinusitis, diabetes mellitus, or other immunocompromising conditions. Bacterial pathogens includes Staphylococcus aureus is the most common causative organism, responsible for approximately 70% of cases. Other bacteria include Streptococcus pneumoniae, anaerobes, and gram-negative bacilli. Fungal pathogens includes, this is less commonly but, CST can result from fungal infections, particularly in immunocompromised patients. Causative organisms include Aspergillus and Rhizopus species and are often associated with invasive sinusitis or mucormycosis. Aseptic cavernous sinus thrombosis, though rare, may result from facial trauma, surgery, hypercoagulable states, or malignancy. In these cases, no infectious organism is identified. Other etiologies include aneurysm of the carotid artery, a carotid cavernous fistula where orbital bruit may be present, meningioma, nasopharyngeal carcinoma, other tumors, or an idiopathic granulomatous disorder that is Tolosa-Hunt syndrome. Next, clinical presentation. The clinical presentation is usually due to the venous obstruction as well as impairment of the cranial nerves that are near the cavernous sinus. Headache is the most common presentation symptom and usually precedes fevers, periorbital edema, and cranial nerve signs. The headache is usually sharp, increases progressively, and is usually localized to the regions innervated by the ophthalmic and maxillary branches of the fifth cranial nerve. It often presents as orbital or facial pain, orbital swelling, chemosis due to occlusion of the ophthalmic veins, oculomotor neuropathy affecting the third, fourth, and sixth cranial nerves, and trigeminal neuropathy affecting the ophthalmic, V1, and occasionally the maxillary, V2, divisions of the trigeminal nerve. As the two cavernous sinuses directly communicate via intercavernous channels, thus without effective therapy, signs appear in the contralateral eye by spreading through the communicating veins to the contralateral cavernous sinus. Eye swelling begins as a unilateral process and spreads to the other eye within 24 to 48 hours via the intercavernous sinuses. This is pathognomonic for cavernous sinus thrombosis. The patient rapidly develops mental status changes including confusion, drowsiness, and coma from sinus involvement and/or sepsis. Condition worsens follows shortly thereafter. Let's look at the treatment. In infectious cases, prompt administration of broad-spectrum antibiotics, drainage of any abscess cavities, and identification of the offending organism are essential. Anticoagulant therapy may benefit in cases of primary thrombosis. Repair or occlusion of the carotid artery may be required for treatment of fistulas or aneurysms. Differential diagnoses: orbital cellulitis, periorbital infections, Tolosa-Hunt syndrome, meningioma, rhinocerebral mucormycosis.